Hello everyone. The webinar we will be covering today is investigating the possible impaired physician. Don't forget to take notes and complete the exam at the end of the presentation. Detecting, deterring, and monitoring. Before we begin to talk about the impaired physician, we must define what impaired means. According to the American Medical Association, AMA, an impaired physician is any mental, physical, or behavioral disorder that interferes with the physician's ability to engage safely in professional activities. Mental, physical illness, and substance abuse are also the possible impaired physician. Let's focus on mental for a second. A mental disorder is conceptualized as a clinically significant behavior or psychological syndrome or pattern that occurs in an individual as is associated with the following core characteristics according to the DSM-4. Present stress, a painful symptom, disability, impairment in one or more important areas of functioning, and significant increased risk of suffering. B, a physical illness or condition including but not limited to those illness or conditions that would adversely affect the cognitive, motor, or perceptive skills. And C, substance abuse-related disorders including the dependency of drugs and alcohol are also considered impairment. Substance abuse continued. Detection of a physician impaired by substance abuse is a challenge for investigators, since a physician's practice is often the last segment of life to be impacted. When colleagues are ethically obligated to report an impaired physician, they are less likely to do so if the physician's career and reputation will be destroyed. This according to the Journal of Global Drug Policy and Practice. Some signs the detecting of an impairment for the investigator. According to the American Medical Journal of Ethics, there are signs of detection in the workplace or work-related symptoms. Number 1, late appointments / increased absences and unknown whereabouts. Unusual rounding times, either very early or very late. Increased patient complaints. Increased secrecy. Decrease in quality of care and careless medical decisions. Number 6, increased conflict with colleagues. Number 7, increased irritability and aggression. Number 8, incorrect charting or writing of prescriptions. Number 9, decrease in productivity or efficiency. Number 10, smell of alcohol or overt intoxication, needle marks, runny nose, or bloodshot eyes. Number 11, look for unexplained documentation. Number 12, unexplained missing inventory. And number 13, suspicious computer log entries for pain meds. Number 14, not returning waste at the end of the procedure. And number 15, volunteering to clean an operating room after procedures. According to the AMA, these are some of the behavioral / signs that an impaired physician may display while in the workplace. The investigator should be inquiring about these actions from the impaired physician's colleagues, nurse, technicians, and any other person the physician may have contact with. Detecting signs of impairment for the investigator. The impaired physician's personal life. Investigators should look for 1, withdrawals from friends, family, and community. Legal trouble. Search for any arrest, DWIs, possession of controlled substance. Change in appearance. Number 4, increased vehicle accidents or accidents at home. Number 5, increased visits to the doctor. Number 6, increase in aggression and overt conflict. Number 7, financial difficulties. Number 8, personal hygiene. Number 9, emotional disturbance, depression, anxiety, mood swings. And number 10, what peers say about the impaired physician. You can learn a lot from talking to other people that the impaired physician surrounds himself with, or the distances that he puts between his friends or colleagues. These are signs and investigative clues that will help the investigator determine if the impaired physician is impaired or could possibly have a substance abuse problem. It should be noted by the time these observations materialize, this could be the last call for help with the impaired physician. Abuse of alcohol didn't just start when you were notified. This illness could have been going on for 15 years before it was reported, or the impaired physician realized they needed help and it is having an impact on their skills. However, with fentanyl users, they may require intervention within months. One study found the mean duration of physicians' substance-related problems before treatment was 6 or 7 years. This was according to the AMA Journal of Ethics. Most impaired physicians will deny they are impaired, and they will be very convincing because they've had years of practice in covering up their illness. From my years of law enforcement experience, an addict, whether it's alcohol or drugs, will not admit they have a problem until something tragic happens in their life. Now let's talk about deterring the possible impaired physician. While many physicians know which physicians have a substance abuse problem, they will not turn the impaired physician in. A 2002 ethics survey found that 65% of physicians would report an impaired colleague to the state medical board. However, many experts believe that this number simply reflects the physician's understanding of what they should do rather than what they would actually do in this situation. This is according to the Journal of Global Drugs Policy and Practice. To deter the possible impaired physician, some think each physician should be subjected to random drug testing like any other hospital employee. Statistics have shown that random drug testing will curtail the impaired physician. Each physician is obligated to report any physician that they believe is impaired, and there should be clear policies and procedures for this to be done, whether it is a hotline number to an independent agency or to a physician health program. Continuing on with deterring, each time a Schedule II is signed out of the pharmacy log, it should be witnessed and destroyed by 2 individuals. Each time a Schedule II drug is administered, it should be witnessed by another individual. One more important issue is to remove the stigma that addiction is a crime and change the perception to illness. This can only be done through education in the medical schools, hospital, and state medical boards. There should be a great working relationship with state boards, medical school, organization, and physician health programs to support each impaired physician. The stigma must be removed from the issue, and focus should continue to be on treatment if we are truly going to deter the possible impaired physician. Deterring the possible impaired physician continue. There must be clear examples of those that suffer from addiction and how they turn their life and profession around. These physicians must come from out of the darkness and made to feel it acceptable to tell their story in order to help someone else. Also, each state board must be willing to spend the funds on educating physicians on the dangers of being impaired and must be willing to help instead of discipline. Now let's talk about monitoring the impaired physician. There are several good programs in each state that monitor impaired physicians. They have regular drug testing through urine, hair samples, and fingernails. Some also provide education that teach the impaired physician how to deal with stress. Continuing to monitor an impaired physician is very costly to the impaired physician. In some programs, when an impaired physician is tested, it could cost $200 or more per test. And some impaired physicians not only test with programs, but also maybe tests by their state board. However, the impaired physician must come to grips with the fact that they have a disease, and the first way to live with this disease is to admit the illness. Once the impaired physician is released from a treatment center, it is imperative that he/she continues with treatment. Some other programs included for the impaired physician to attend are AA and NA meetings with a sponsor. These programs are lifelong because there is always an opportunity for relapse. In monitoring programs, there should be a great working relationship with the state boards. Memorandums of understanding must be in place to have a cohesive working relationship. It is very important there is a trust, openness, and honesty among the state board and the monitoring program in order for the impaired physician to succeed. An impaired physician that seeks treatment from a PHP should feel free to report his information to the state board. If no patient care has been impacted and there have been no criminal or civil charges, then no discipline should be administered. Lastly, as an investigator, we must remember that an impaired physician will do anything to disguise, hide, and deny their illness. It is not that they are trying to be difficult or hinder your investigation. They are merely trying to protect their careers, and they feel cornered. It is up to the investigator to use your interviewing skills to make the impaired physician feel comfortable during the interview, to be able to express him or herself. While conducting these interviews, you should try to use your active listening skills to induce the conversation. Try not to be accusatory and use empathy. Remember, the most important thing of all, you as an investigator are here to protect the public, and if you can stop an impaired physician from practicing before he receives therapy, you have done your job.